So today's topic is ECT, TMS, DBS, an overview and comparison. So I started here because I realized that I was working on this last night at my daughter's dance studio, and I had a number of people, as I was trying to tell them what I was doing, I realized that it was just all letters to them, kind of like alphabet soup, where it took a lot more explanation. So we're going to do a big picture overview and general comparison. If I manage my time appropriately, we can talk a little bit about some of the details related to the efficacy of each of the comparisons, but it's really just an overall big picture view. So I don't want you to be disappointed. So our objectives for today, we're going to outline what the use of electroconvulsive therapy, repetitive transcranial magnetic stimulation, and deep brain stimulation entails. So what do those mean? And then we're going to identify some appropriate populations for the use of each of these and highlight some adverse effects that are associated with each of them. So all three of them are forms of brain stimulation. They're not the only forms of brain stimulation, but there are three that have approved indications that have existed for a while that do have a relatively robust database of evidence to support their use. So we do have a little bit more experience with these. And it was a good opportunity to put the brain from Pinky and the Brain in my slide presentation.
I love brain.
Always look for opportunities to do so. So I wanted to start with ECT. So ECT is our most long-standing brain stimulation intervention. It is not what it looks like from the movies. So this is a picture from One Flew Over the Cuckoo's Nest. ECT now, if you're to go and watch, if you don't look carefully, you would barely even know that anything had happened to the patient. So it is nothing like what gets depicted out in the lay media. And I think that's important to reinforce with everybody because we are instituting seizures, but it's not like this. So if that's the only thing that you remember from today, my lecture will have been successful. So what actually is ECT? So it's electric current that's applied through electrodes. So patients are prepped. This has to be done in a facility. They do undergo general anesthesia and they're given muscle relaxants. So they're given sedation to put them to sleep, and then the muscle relaxants are to help prevent any type of muscle strain or potential muscle injury from the seizure that gets induced. So patients come into the facility, they're prepped, they are sedated, they have electrodes that are placed around the head. The electrodes are activated to create a seizure, and then the patient will go for post-ictal recovery. So this entire process, the seizure induction till when they're post-ictal, may take between 5 and 10 minutes. There are different forms of ECT. There's one form that's called multiple monitored ECT, and that might be multiple activations to stimulate seizure activity. So in some cases, seizure activity is stimulated maybe once for 15 seconds, 30 seconds. It may be done a couple times, so usually no more than 10 times in a single episode. There does need to be a little bit of a delay in between the different seizure activations. The reason for that, the brain uses glucose and oxygen that's delivered to it. It's relatively efficient in being able to extract both of those. When we have seizure activity, the brain activity is up higher, so its demand for glucose and oxygen goes up. The only way to get more fuel delivered to the brain is to increase the blood flow that goes to the brain. So if we have a seizure that goes too long, then at that point you are at risk for having the patient experience some hypoxia in the neural tissue. So they do tend to be brief seizures. There may be a break in between, but they can have multiple episodes in one particular treatment course. So when they set these up, patients sometimes can be inpatient. They do have to come to a facility for the treatment, but they also can be outpatient. The seizure episodes are usually administered about 3 times weekly. For some maintenance patients, it may be less than that. It may be once or twice a week. For a course of ECT treatment, it really is variable. So minimum of 3 sessions, unless the patient's unable to tolerate it. After 6 sessions, there should be some degree of improvement that's seen. If there's not, it's recommended that some changes take place. And the alterations that take place, it can go from bilateral electrode placement and stimulation to unilateral or vice versa, and they can change the stimulus intensity. So to make it a little bit more robust, an experience or a seizure to try to get that efficacy. If after about 9 to 10 sessions, if there is no improvement, it's recommended to discontinue the ECT therapy, that this is not likely to be beneficial for the patient. If the patient does respond, if they go into remission and all of their symptoms are gone, patients often will continue with maintenance ECT for 6 to 12 months afterward. And in some cases, even continue longer than that, especially if they've been refractory to other treatments. So in some cases, it may be brief. In other cases, you may see patients on this much more long-term. So who should get this? We're not sure exactly how this works. So the seizure activity does result in changes in neurotransmitter levels as well as neuroplasticity. In the brain, it increases the levels of brain-derived neurotrophic factor. So there's a number of different features that seem to happen when the brain seizes. Because of those, it's been found to be effective mainly for major depressive disorder, for bipolar disorder, as well as for schizophrenia. It has been looked at for refractory forms of anxiety disorders and post-traumatic stress, but these 3 particular conditions tend to be the most frequently used. 80 to 90% of patients who are getting ECT are getting it because of a depressive episode. So it primarily is in that patient population. So advantages. If a patient has major depressive disorder and we need really rapid response, ECT is well, now we have ketamine. I was going to say it's the primary treatment intervention to get rapid response. It had been the only one that we had to really get that robust response initially. It also has been shown to be more efficacious than pharmacotherapy for treatment of severe suicidal ideation, as well as catatonia. So it tends to be utilized relatively frequently in patients where healthcare professionals feel like they may not be able to keep the patient safe. So that's when it tends to move up a little bit higher in therapy. There are some patients we can't use it in. So patients that have increased intracranial pressure, because it can do damage, especially when the seizure activity happens. Patients who have masses, aneurysms, hemorrhages, or vascular malformations in the brain itself. And then also there are some cardiovascular complications. So patients with pheochromocytoma, as well as a recent MI, are not candidates for ECT. When the seizure is being induced, there's stimulation of both the sympathetic and parasympathetic nervous systems, which can cause relatively significant alterations in blood pressure as well as in heart rate. Patients do tend to have spikes in their blood pressure and heart rate and an increased demand for myocardial oxygenation. So if the heart itself is damaged, it may not be able to compensate for that increased need during the seizure activity, even if it's just for that brief duration of time. So not an option for everybody, but definitely an option for quite a few patients, usually adults that may be suffering or not responsive to other treatments for these conditions. On the flip side, what are the adverse effects? So the most common adverse effects from ECT are nausea, headache, and sometimes some muscle soreness. The ones that are of most concern are cognitive effects. So patients can have confusion, disorientation, as well as memory loss from the seizure activity itself. That tends to last for minutes to hours after the event. It's not uncommon for patients to be a little disoriented following the seizure treatment, and they can have amnesia, both anterograde and retrograde amnesia surrounding that time. So they may not remember anything of the prep before they went in for that session, and they may have difficulty remembering things for the remainder of that day. So from a functionality standpoint, if you have a patient who is outpatient, they shouldn't be driving. They shouldn't be driving in for the ECT treatment because they may have some difficulty afterwards, so they would be unable to drive home. There also can be some cardiovascular effects. So it is possible that some patients can develop arrhythmias or have some other cardiovascular complications as a result of it. That tends to be just during the ECT itself. Once the seizure activity has ceased and they're in the recovery process post-ictally, those cardiovascular effects do tend to resolve. So the cognitive ones really tend to be the biggest problem for a number of patients. It is unclear if it's additive. There are some studies that suggest that patients who had long durations of ECT do have some cognitive impairment, but the confounder is these patients also tended to have really refractory mental illness, and that can itself cause some cognitive impairment. So it's not totally clear if it's due to the condition itself or to the treatment. So it is something that we do want to watch. So that's the most common, is ECT. The next intervention is repetitive transcranial magnetic stimulation. So I'm just going to refer to this as TMS. So TMS is just what it sounds like. So this is using magnetic stimulation to activate the brain. It can be much more targeted than what ECT is. So ECT had the electrodes that were attached to the patient's head. This actually has an electromagnetic coil that's held to a particular area of the patient's head. The coil is activated, and the electromagnetic pulses can stimulate different electrical currents. So it may inhibit or activate different brain areas. What's interesting about this is it actually can be a little bit more focused than what we can get with ECT. So they can move it around to different areas of the brain to focus on a particular area that may be more beneficial based on the indication that we're using it for. It also doesn't cause the same amount of adverse effects because it's not involving all of the brain tissue. It does tend to have a more focused area of action. It's primarily used for depression. That's what it has its approval for, but it's been investigated for treatment of anxiety as well as psychosis. And it's being looked at, interestingly, for some substance use disorders. I pulled this one specifically just because it's not consistently effective for substance use disorders. The best evidence they have is for patients who are suffering from nicotine dependence, alcohol dependence, or cocaine dependence. You'll notice one of them that's not on there is opioid dependence. There was inconsistent data to support the use of TMS for opioid use disorder, so it really isn't necessarily recommended for that. They are doing a couple other pilot targeted trials, but it didn't seem to be as effective for that group. So TMS uses both high frequency and low frequency stimulation. So high frequency, it can excite different areas, which may be really beneficial for patients with depression. Some of the low frequency can actually cause an inhibitory effect on brain circuits, and that may be helpful for conditions such as anxiety and psychosis. There are a number of different procedures for using TMS, and quite a few of them may use both high and low frequency settings to be able to target different areas in the brain. So some of them will use different patterns of these frequencies. Some of them may only use one or the other. So it depends on the center that you sent them to, as well as what they think would be most effective for the patient. What are the adverse effects of TMS? So there can be discomfort at the magnet placement site. So wherever the magnet was located, there can be some muscle contractions. They may feel like they have muscle spasms. They may feel some tingling that occurs during the procedure. it's no more uncomfortable than what patients tend to experience when they have MRIs. So they may hear a knocking as the electromagnetic current is going into their brain. But for the most part, it's not necessarily going to cause them any physical harm in the area. After they've had the intervention, they may experience some headache or lightheadedness. It is possible that patients can have seizures, although in some of the depression trials, there was only one seizure that was reported, and it was unclear if it was due to the intervention itself. When they compared the adverse effect profiles, they actually found it was as well tolerated as the sham or placebo intervention. So it does look to be relatively safe. I had one more thing I wanted to say about the TMS. So patients who have this, they tend to have daily or most days of the week treatments. So they'll go 5 or 7 treatments per week for the first 4 weeks, and then they'll have treatments maybe 2 or 3 times a week for the from there on as far as maintenance therapy. So there tends to be almost like a loading of the intervention where they get it most days for the first month, and then it does back off for maintenance. They have used it relatively long-term, especially in depression patients. It has not been reported to have a loss of efficacy over time, although it is relatively modest. I think it's like 18 to 24 months is the longest data that I saw. So the last intervention is deep brain stimulation, or DBS. So DBS is much more invasive. So TMS is just on the outside. ECT kind of attaches to the brain and then causes activity in the brain. DBS actually goes into the brain itself. So this does require surgery. Electrodes are implanted in the brain, and there's a generator that's implanted in the chest. So they're attached, and the generator provides continuous stimulation through those electrodes on a regular basis. That can be controlled on the outside with, it almost looks like a BlackBerry or a VNS interrogator, where they can adjust some of the settings for the DBS. Interestingly, patients are awake when the electrodes are implanted, so they are sedated, but they're awake to be able to respond to the placement of the electrodes, and then they're put under full general anesthesia for the placement of the generator in the chest. So candidates for DBS, they have to be stable enough to undergo surgery. So that may not be appropriate for some patients that have a number of uncontrolled comorbid disorders or concomitant medical disorders. Patients who have dementia or those that have brain lesions are also considered not good candidates for DBS. It's been used most frequently in patients that have movement disorders, so essential tremor, Parkinson's disease, as well as dystonias. It's also been approved for treatment of OCD. It's been investigated for a number of other conditions, with depression and epilepsy being those that are reported most frequently. It's interesting because some of the movement disorder data, so sometimes there is a split between neurology and psychiatry. In the movement disorder data, when they were looking at DBS, they specifically stated that it was not recommended for use in patients with psychiatric disorders. And then it's been used in patients with OCD and depression, as well as schizophrenia. So depending on the literature you look at, it may look like it's not supposed to be used in mental health disorders, but it definitely has some efficacy there. They're not sure exactly how this works. The theory is that by having the electrodes implanted, they're able to reset some of the neuronal circuits. So most of the circuit, they can place the electrodes anywhere, but most of the circuits that they work on are the cortico-basal thalamic circuits. Again, because we were looking at the movement disorders, that was where it started from. They have started testing other areas with a varied amount of success. So looking at different conditions and different placements makes it a little difficult to be able to say this is definitely more effective because they have to test location and indication and then compare the two. But there's a whole bunch of research going on in this area currently, both in animal models as well as in humans. So from an adverse effect standpoint, there are some procedural risks. So bleeding in the brain is possible, confusion, infection, lightheadedness. Patients may experience some mood changes and movement disorders following the procedure. So these would be new movement disorders, even though the DBS was implanted to help with tremor or Parkinson's disease. And there have been reports of patients having a stroke after the procedure. With the DBS itself, there are some adverse effects that have been noted after the patient has healed from the surgery. Most of them are psychiatric or neurologic. So from the neurologic standpoint, for individuals who have used DBS for at least 2 years, there have been some noted cognitive impairment, so a deterioration in their cognitive functioning. Some patients experience gait changes as well as speech changes that can be relatively significant and do not seem to develop a tolerance to. Those changes occur and then are persistent as long as the patient has the DBS. There also are some psychiatric adverse effects that have been reported. So there's an increased incidence of depression in some of the patients, which is interesting because they're also investigating DBS for the treatment of depression. And that was where they were looking at probe placement to try to look at some different locations to maybe assist with that. And there also is an increase in suicidal ideation in these patients. So it's unclear if there's a particular area that's exacerbating that, but that is an area of concern. Other side effects that patients have experienced are urinary incontinence as well as weight gain. So just as a quick recap, I tried to keep this as a blitz, although I went a little longer than I wanted to. So ECT, inducing seizures, so direct stimulation inducing seizures, best evidence for mood disorders as well as treatment of psychosis. TMS is our magnet that goes on the outside, so least invasive, has the best evidence for treatment of depression at this time. DBS, implanted stimulation, so the most invasive that requires surgery and tends to be much more permanent. Best evidence for movement disorders, essential tremor and Parkinson's disease, but also is effective for OCD, which is helpful because our medications are not always as effective as we want with that particular condition. And with that, I will turn